answer all those questions. And then also at the end, I will go ahead and take everybody off mute, and you'll be able to go ahead and answer or ask questions as they come up. So whichever way works the best for you. All right. And as a future, one more caveat I want to say is that if you plan on getting involved with any of the AIM projects moving forward, I am going to kind of require this as a baseline just for general understanding and just for level setting as we move forward. So we can jump right into the business. All right, so what is AIM? And these are my slides, but they're not my slides. So a lot of these slides will actually be from the national AIM chapter, but I've integrated some specific to Virginia in throughout the presentation. So AIM is the Alliance for Innovation on Maternal Health, and they are actually a recipient of a HRSA grant. I'll talk more about that here shortly. They are under the national ACOG chapter, and they do work with the Council on Patient Safety in Women's Healthcare. All right, so what is AIM? AIM is currently funded by a cooperative agreement with the U.S. Department of Health and Human Services, or HRSA, as a lot of us know it, or MCH Bureau, which is the Maternal and Child Health Bureau, and the ACOG chapter of OBGYN, or ACOG. It is a national cross-sector commitment to promote safe care for every U.S. birth and lowering the U.S. rates of preventable maternal mortality and morbidity. And then through state teams, which is us, the Virginia Neonatal Perinatal Collaborative, and health systems, AIM aligns national, state, and hospital level quality improvement efforts to improve overall maternal health. So AIM's primary objective, we just highlighted it a second ago, but it is to reduce preventable maternal deaths and severe maternal morbidity, or SMM in the United States. So how do we do this? We do this by engaging multidisciplinary partners at the national level, developing and providing tools for implementation of evidence-based patient safety bundles, utilizing data-driven quality improvement strategies, and aligning existing efforts and disseminating evidence-based resources. All right, so these are, as of April of this year, these are the current states that are enrolled in AIM. And as you can see, Virginia is over here, blue. And I will say that some of these states are in the process of adding to. So currently there's 41 enrolled AIM states, including the District of Columbia. And in those states, this is what we want to highlight right here. There are over 1,900 birthing facilities that are engaged in AIM. And by the end of this year, the program expects to bring on 5 additional states. So Virginia, as I mentioned, is an AIM state. We became an AIM state in October of 2017. And we are also, as it had mentioned earlier, was HRSA funding receives through the program, but Virginia was one of the earlier states to adopt. So we are a recipient of the HRSA funding through AIM. For complete transparency, we receive annually $9,000. That started year 1 in 2018, and it will go through year 5, which will end in August 30th of 2023. With the annual funding, you can also apply for additional funding, for supplemental funding is what they're calling it. And we applied, the BNPC applied in spring, I believe it was, of last year. And we received an additional $10,000 in supplemental funding. Once we have exhausted the $10,000 in supplemental funding, we can reapply again for additional funding. So if there's a project we want to do, if there's certain things we want to go that align with the efforts, we can apply for that additional funding through 2023, as long as there's funding available. All right, so I'm going to pause on this slide just for a few minutes or a few seconds, just to highlight all of the partners that are involved with these efforts. And for those of you that are or have worked with the VMPC, you kind of see that we have a lot of our partners that exist on the executive committee. So we have the AAFP, we have the ACNM, ACOG, A1, IHI, we, the executive committee and steering committee, a lot of us have been trained with their related to quality improvement projects. All right. Okay, so what is AIM and what is the purpose, like kind of as the work plan and the goals? So as we get these patient safety bundles, which I know everybody's heard about, the goal is to provide and facilitate the integration of those bundles for the 50 states, the District of Columbia, the territories, and the tribal maternal health into AIM. It's to incorporate the respectful, equitable, and supportive care of all people into new existing bundles and other AIM sources, and hence the development of the patient safety bundles. Then they develop, implement a community communication strategy, and then there's developed data metrics for each of the bundles and an online national data collection system. They also collect the outcome data on safety bundle implementation. And then they convene multi-sectional or sector national partnership of organizations, which we saw on the previous slide, and then identify strategies that will sustain the work of AIM. So what is the goal of the national team? So that's the team that's above us, is generally project oversight. I meet monthly with our project coordinator. Each state has their own project coordinator that is assigned to them. And their goal is to assist the state teams in the development of the bundle, implementation work plans, and then offer ongoing guidance to help state teams achieve the program objectives. They also provide engagement opportunities. They do this monthly through calls with other states. They facilitate opportunities for collaboration, learning, and information sharing amongst other state teams, offering include bundle interest groups and the knowledge library. So we can do it by bundle, we can join calls, or we can do it just collectively as states. And then they also offer data strategies. So they support state teams with the development of a data collection strategy that meets local needs. So we have a data dashboard that we can provide our information into. Providing resources to enable ongoing collection and reporting of hospital level data. So that data collection is by hospital, but then it goes collectively for the entire state. And then we can compare to other hospital like sizes across the country or other states across the country, how they're doing related to that bundle. And then they also provide budget guidance through the design and project budgets and strategies for effective utilization of the HRSA funds. So again, this is one of the things I talk with monthly with our project coordinator. All right, so the data center supports data-driven quality improvement. It provides benchmark metrics against like hospitals and stratifies outcomes by patient demographics. So when I say like hospitals, they have it color-coded by the number of deliveries annually. So if you pull up the metrics, you'll be able to see your hospital, and then you can compare it to other hospitals similarly, but they are de-identified. So you won't be able to see, oh, that one's VCU, that one's UVA, that one is Carilion. You'll be able to just measure yourself like other like hospitals. Allows for comparison across state collaboratives, and then it tracks bundle implementation and SMM rates over time. The SMM rates over time, in our dashboard, we go back to 2015, and that is state level data that gets put in by hospital. All right, so the AIM data measurement, there's 3 different types of AIM measurements. We have our outcome measures, our structure and process measures that we collect with each of these bundles. So our outcome measures are calculated and submitted on behalf of hospitals by collaborative administrators. Data, and it's data primarily sourced from hospital discharge and birth certificate data. The structure and process measures is the data that's collected by participating facilities and submitted by the hospital administrators. And then this is based on the AIM data collection plan. So our individual work plans that are provided from the state level to the hospital level. And then data from other AIM states provides collaborative-wide data for other metrics provided by all states, which also allows for improved benchmarking. So the AIM data center uses, this kind of puts it all in a graphic format. So we have our participating hospitals that track their process and structure measures over time. They monitor facility-specific outcomes, and then they benchmark against other like hospitals that are located or that are within the collaborative, so that are also submitting through the VNPC. The statewide collaborative then tracks the bundle implementation and data submission across each of the facilities, so each of the hospitals in the collaborative, and then they use this data to assess facilities and collaborative impacts, and then they use this for benchmarking against other collaboratives. And then at the national level, they track this bundle-wide across the nation, so they can look down and see all the states within the country that are implementing the obstetric hemorrhage bundle, and then they can tease apart the different data from that. They also determine areas of program support and improvement, and then they evaluate program and analyze impacts. So what is specifically the patient safety bundle? So these bundles are a structured way for improving process care and patient outcomes. So they're small, straightforward, and evidence-based. I think that's the key word right there, evidence-based. The power of these bundles come from the body of science behind it and the method of execution, which completes consistency. So it is the guiding framework for all of these hospitals on how to execute and implement a specific bundle to improve this set of outcomes. So it's performed uniformly across all hospitals, across all states. And then the bundle ties together the change, or ties the change together into a package of intervention that people know must be followed for every patient every single time. All right, so here are the patient safety bundles that are currently being offered. The maternal sepsis one will be coming late next year. And we completed this one in 2020 with the VNPC. We have started this one, and then they national chapter has actually pulled this one back, and they are based on lessons learned and improved best evidence practices. They are currently redesigning this one right now. And we will be launching this one, or what we're calling it, is the 4th trimester at the end of this year. There's another slide about that at the end. Okay, so what are the bundle components? So now we're at the bundle level. There's 5 components. The 5th component was added last year. So some of you may previously only know the 4 bundle elements, but now we have 5. So it's the 5 R's. You have your readiness, which is, are you ready to, what are the main components that you need to be ready to implement this bundle in a timely response? We have recognition and prevention, which recognizes the signs and prevention of the crisis. So if we're working with OB hemorrhage, what do we need to do to recognize the signs of OB hemorrhage and prevent it from occurring? The response is developing protocols that are put in place to ensure better future outcomes. So it's how we're going to respond to it. And then the reporting and systems learning is the active learning based on the data that we collect. So if we collect the data, this is where your PDSA or your plan, do, study, act cycles come into things. And then respective care, which is the new R, and probably the most important one, and I think we can agree this is the most important one, but it's respectful care, ensuring a set of standard practices that would ensure equitable encounter for every patient every time. So we seek to integrate this. This is currently being integrated into all the previous bundles as they speak. And then moving forward, it will be a component of every bundle moving forward. So equity isn't only regulated into the 5 R's, but should be infused into each of the R's across it. So there should be respectful care integrated into the readiness of it. Respectful care should be integrated into the recognition and prevention, into the response. So it's separate and then inclusive in each of these components. All right. So what do we mean when we say respectful care? The goal is to build a patient safety culture centering on equity, teamwork, and open communication. Again, for every patient, every time. They recognize that providers have a lot of work that needs to be done in imperfect systems, and that they also seek to address this as a whole. So championing this with AIM and ACOG allows them to work with patient advocates with lived experiences and organizations, partnering with organizations like NBEC, Indigenous populations, and then the LGBTQ plus populations, looking to serve all populations in an intersectional way, and then to ensure an equitable dynamic of power in healing the whole person, patient-centered, trauma-informed care for every patient in every clinic encounter. So what does AIM look like in Virginia? So we are currently in the process of holding subject matter experts meetings. And with these meetings, we're trying to establish what the goal of the bundle will be as we implement it in Virginia, specific to the 4th trimester. But this is the kind of the template and the outline for all of our bundles. We are developing activities or your best evidence practices to be implemented within each of those 5 R's. And then we're also creating and developing tools, specifically work plans, checklists, and metrics are provided, but how to actually collect that information. So then we will collect baseline data. Then we will onboard hospitals and communities that are interested in participating in the projects. We will launch the project, providing monthly technical assistance calls and or mentor calls. So this will be with other systems that are undergoing the same things for lessons learned. Where's your challenges? Where's your barriers? And help to learn from each other. We'll also conduct one-to-one calls and technical assistance with each of the systems, and then collecting monthly data for PDSA cycles, and then giving data back in a timely and meaningful way. Oftentimes that works as a run chart so they can see where they started, where they're going, and where they want to go. And then recommending change or a change package based on the data, based on the run charts for each of the systems, and then helping them to conduct another PDSA cycle. All right, I know that was a lot of information in a relatively short amount of time. So I'm going to actually stop sharing and see what questions we have. And as I mentioned, you can either chat them in, or if you want to, you should be able to raise your hand and then I can take you off mute if that is easiest for you. So I'll ask a question first just to kind of get this conversation going, but how many of you have implemented a patient safety bundle into your system through AIM or through working with the VNPC? Donna, I unmuted you. So you've implemented it. What were some of the lessons learned, or where were some of the challenges from that patient safety bundle? If you don't mind unmuting. I see you're unmuted, but I can't hear you. I'm wondering if there's a double mute. All right, Lori, yes, I see that UVA has implemented. Lori, do you want to text in, or do you want me to unmute you? And if you're willing to share some of the challenges or barriers or some of the successes that you had with implementing the bundle. All right, you're unmuted. You might have to unmute yourself as well.
Okay.
There you
Did
go.
that work? Okay. We implemented the postpartum hemorrhage bundle. And the first component that we did was we switched from estimated blood loss at delivery to quantitative blood loss at delivery. And we instituted that first with C-sections. And then after a few months where people got used to that, we implemented it into vaginal deliveries as well. That was much more challenging because many of the residents did not remember to save laps to be weighed. So that took some doing because it was, it's not as much of a surgical procedure as a C-section. So they just didn't process that it needed to be done. And then we went to, the next step was we started doing quantitative blood loss from the time of delivery until they transferred over to mother baby. And then a few months, 2 months or so after that, we started actually doing a quantitative blood loss for 24 hours. And to be honest, I don't know how well that went on postpartum or mother baby because I wasn't on that unit, but to extend a quantitative blood loss to evaluate postpartum hemorrhage for a full 24-hour period did seem to be a bit challenging.
Yes, thank you. One of the things you mentioned, Lori, that I definitely saw in the data across the state as I was looking at the OB hemorrhage with that data as it was coming in, it was very interesting to see the number of providers who received training related to the protocols and general OB information versus or practices for that floor versus nurses. Inevitably, our nurses were between 90 and 100%. Received the training, was aware of the protocol, knew where the hemorrhage cart was, and was well adapted to that. The providers, on the other hand, ranged anywhere from 20% to 100% receiving the training. I think you brought up one of the challenges or the barriers is the turnover or the constant coming in and out of with interns or residents or fellows. And so keeping them up to date with the protocols can be challenging. The other thing we specifically in our community hospitals is recognizing that some community providers only deliver once a month, or they're in the hospital once a month or twice a month. And so to get them trained and up to the standards is a challenge. And so that's one of those areas of opportunity that we were able to identify with our PDSA cycles based on the data. So thank you, Lori, for that information.
Shannon,
yeah.
One other thing that we did, particularly for nurses, we did simulation drills with postpartum hemorrhage and had everybody play all the roles. So, there was a patient, there was a partner, there was a doctor, there was a nurse, there was a runner to go get blood, there was somebody who got the hemorrhage cart, because simulation drills for something that is high risk but low frequency are often a very good way to keep staff up to date. We did have some physicians who participated in that, but I would say probably reflects the data that you saw, that it was probably 90% nurses and maybe 20% physicians. So, how do you manage to get more physicians to participate, whatever your level of training is going to be?
Right. And I still, that is definitely $1 million question that we still need to work with. And I think this is where the opportunity comes into as we can hold one-on-one calls with other systems from a mentor's perspective, what has worked in other systems, what has, not worked, where their challenges and barriers continue to be. We can learn a lot from each other. That's part of the reason why I'm constantly on the monthly calls, because I do learn a lot from other states where they've had these similar challenges and how they've overcome that. So thank you for that. So Donna was able to chat in, and she's from Carillion, and did say that they have implemented the C-section bundle, the SSI, PPH, VTE, and hypertension bundles. Their biggest challenges, again, has been getting stakeholders on board initially and now getting timely changes into the EMR. So EMR does also seem to be one of the challenges to have it update or to integrate some of these questions with that. And then we've circled back around to each to assess that changes haven't gotten just stuck. So none go fast, and then all takes time and patience. Absolutely. And so this is where your PDSA cycles really come in. And then it's also, how do we ensure that we maintain sustainability once we've already implemented, we've gotten the data that we want, that we don't get lax when we go to implement another project. So definitely excellent points. And Francis Williams, I wanted to respond to your question. So are you looking at projects regarding disparities in healthcare? So that's excellent question, but this is what AIM has done. And that is where that fifth component comes in with that respectful care. So AIM used to have a specific bundle separate related to or regarding to disparities in healthcare. And so it's always been that debate. I remember this debate when I was working on the infant mortality strategic plan. Do you pull out a section to discuss disparities in healthcare and how to overcome them, or do you include that in each of the other activities that you've done? So initially AIM pulled it out, and then after a lot of discussion, a lot of conversations, they decided to add it into everything they have done. So there should be, for each of the bundles, there's the fifth R, which is respectful care, which is working with different populations. So how does obstetric hemorrhage impact each of your populations that you serve at your system? And what are you specifically doing based on your data for each of those populations? Do you need to do something different? Is it education? Is it awareness? Like, what is it? Listening? Is it hearing her? What do you need to do differently for each of those populations specific to that topic? And then it's also taking that and putting it into the readiness. So is it an awareness port of it? That goes with the readiness. Is it a recognition? Maybe the education is written at a 10th grade level and you have low literacy rates for your population that you serve. And so it's putting that information into a 3rd or a 5th grade level of understanding so that they can have that. Or it might even not be literacy, it's a low health literacy rate. So it's really understanding your population and who you serve and your patients at each of those 4 levels. And then the 5th one specifically, is there something that needs to be pulled out? So AIM has made the decision to actually integrate respectful care, or as you're referring to it, regarding disparities in healthcare, into each and every bundle and each and every component. And then Francis also mentioned that at Virginia Hospital Center, they've implemented the DVT and hypertension and prevention of first cesarean bundles, still looking for outcomes, planning on implementing the postpartum hemorrhage and then QBL this year, hoping to get something regarding disparities going, and wonder if anyone has experience with that. So as I mentioned, and I'm happy to talk offline, Francis, but we're really integrating it in everything that we're doing, and being much more intentional with it. So, all right. Does anybody else have any other questions?